Welcome to the first video on assessing CCI related symptoms and looking for the morphometrics or measurements in medical imaging. And we're going to look at the PubMed Central article on Clivo Axial angle assessing for brainstem conformity. And of course, that's what this will look like here. And this is what we're going to be demonstrating on how to do it. The article will be in more depth as far as what they're looking for as normal neutral is roughly around that 150 and could be a little bit higher in some. And of course, if you look at any other MRIs with just a random study of a thyroid, you can find people with 150, 160, and a little bit higher, and even some at 148, and they're still functioning normal. However, this is a lot more detailed and starts to, as the article will touch on, if you scroll down, you'll see that they're discussing more of rheumatoid arthritis. They're talking about basilar invagination, which you will actually see by that, Chiari malformation. So a lot of the people in this study likely had a lot more going on than simply just a low axial angle. However, it's one of the pieces of the puzzle, but not the full picture. So how do we do it? Simply put, this is of course a person looking to the right. This will be the anterior part of the skull. The base of the skull is the clivus, and we have C2, second vertebrae, the posterior side. Now, there is a mention in here that there are two different versions. If I just could do a control find and type in bone, actually, I think it's soft tissue. But we'll get right into doing the first version of it. So we'll be following this model very simply. So we have an MRI here. And now, of course, a lot of this may not really affect it too much within an MRI, but we know that the outer cortex of bone is a lot more dense and dark. So the tip of the clivus is here, not here. So we're going to take the angle of the clivus, and then we're going to come down, bring this point right at the edge of between the dura. If we zoom in, we can see the outer bone following here and roughly around there. It's not going to make a huge difference in the number, but if you want to be perfect, that's what you would do. Now the next part here, of course, we have the dens, and this can be a little bit tricky because you have some dural infolding and some, maybe there could be a pannus swelling of the tissue, but let's do our best and take the dura as being here. It's probably over here, but C2 is likely probably right there. And that would be the bone portion of this. So now if I do a soft tissue version that you probably see a lot of doctors do, because of course trying to find the a dirty MRI, meaning the patient could have been shaking and things are a little bit hazy. Let's just follow a dural version. So we're going to have the bone one here, and this will be a dural aspect. Some may just do it just like this. So look at the huge difference between those two. So and you'll see, and when we get to the CT scan and the cone beam scan of doing this, you'll see that there are different ways that you have to kind of fiddle around with the axial angle view. So this one might be saying, hey, you're on the verge of pathological. This one, you're perfectly normal. And that would be the bone version. The soft tissue version can make you look a little bit worse. So that's why doing it according to the bone version, that is important. And this is the section I was mentioning earlier, that there is a soft tissue CXA, that's a ligamentous margin of the odontoid. So again, that this is where you get people with pannuses, which is that swelling of that posterior longitudinal ligament, and tends to happen. So now let's just go straight into, again, the main number would be the posterior based on the bone, and you're trying to get your best number right there. All right, now let's pause and we're going to go into or switch over into a cone beam with flexion extensions. Pretty cool. Now, if you're not familiar with cone beams, they are a different way of, you can see how it's like a cone that shoots the ion through, and it gives you an axial view of the patient. Pretty nice quality, and it's 1/10 the radiation. But in the software, you'll see this, the multiplanar change. We're going to reconstruct it to sagittal. And now I have the perfect sagittal view. And now we can do, and this is the same patient. So remember we were at what, 152, and we're going to do a bone. And now look, it actually matches the soft tissue. And that would be roughly where it is. And of course, you can't really see the soft tissue because of the lower quality of a cone beam, but you do get a great view. However, this does not mean that was wrong on the MRI. It could have been just how the patient, because this is an upright sitting down scan versus a supine scan, and that could mean a whole lot of difference based on how the skull might be shifting in the patient. And in fact, we're going to now take a look at translation CXA. And we can see within the reference, flexion of the neck decreases CXA by 9 to 11 degrees. So we're looking at maybe a 10% aspect. So probably go by the rule of 10%, but really just keep in 9 to 11 extension. So of course, that was the other information we were talking about earlier. And Radiant Viewer likes to keep on making new lines. Okay, we're going to click here. Now we're going to keep the neutral on the left, and here's our number. And I'm going to move this guy over. And now I'm going to take flexion, and we're going to change the planar to sagittal. And we'll move this over so we can see it. Slide this guy over. Okay. Now, automatically, you can see something very interesting here I want to point out is look at the tip of the clivus, and then the tip of the clivus here. Now let's just do a posterior line, and I'm just going to do another posterior line. Actually, it's right here. That's about the same distance. Okay. Now wait until we see the flexion. You'll see the difference. All right, let's go into angle. I'm going to come down again, and that, I think I nailed that one right on target. It's probably right about there. So we have a 137. So if we take the 145 and subtract, just subtract 10, and that'd be at 135. So we're 2 points above. We're actually good. So far so good. However, while you're looking at these, always remember you're going to be looking at, you can see a little V sign here in the ADI space, but we're going to talk about ADI space in another video. Now let's bring in extension and change that, and here we go. I do not want to narrow. Okay, nope, not to length. We're going to choose the angle, coming straight down, coming to the posterior side of the bone. Now you can see, look what's happening to the middle portion of the axial angle. So I'm coming up a little bit more higher. So again, looking at that 10 degrees, so to speak. So that we're right at the number. And let's just take a quick look at the arrow. You see how much closer it is to this line. This is going to be a very important thing to keep an eye on while you're doing the CXA, because you'll have to be doing the other measurements. And you can also see the fact that the ADI closed up on the top, that V sign closed up, so there might be some transverse ligament issues going on, but that will be viewed in another episode. And ask whether or not it can be done on X-ray, and I do want to say yes, it can be if the quality is good. And you can see the particular outer cortex of the skull bones here. So you have the empty cella right here of the pituitary gland, and you can see usually it wraps up, starts that occipital uh, path going this way. You can see the little line, and you can usually see the end of the clivus right here. And if you got some good eyes, you can usually just get that there. And of course, again, not everything's perfectly flat. And if you can zoom in, you zoom in on it, you can see the outline of this of the C2, the dens, and those little bulbous aspects right here. So now I'd have to follow that as well and to pull back. Now, of course, I'm not using the angle tool yet, and I'm getting more than I need to. And so right about there. All right, so that would be that's the path. So now all I need to do is change over to, no, I do not want length, I want angle. And so I can just simply grab my tools and just put this on my dots, line up those, and now boom. So on flexion, looking down, which is not doing it the correct way, but at 148, that's not normal. And obviously, you can see that the patient's not instructed to look down. They're doing it with just the chin, not with the chin to chest. They're doing more of a chin tuck looking down. So unfortunately, you also have to look at were they doing it the right way. So the tech did not guide the patient the proper way. So it can be done with that. And let's see what else can we show you real quick before we close out. Here's an example of problematic. So if you get a sagittal where you never see the clivus at all, switch over to just making sure there's no patient data here. So you come from there to click into the axial and then change again the multiplanar to sagittal, and then then you get then you can get your full skull picture. So if that ever happens on your CT angiogram or any CT scan, if they block out the sagittal portion, which is annoying, then just switch over to axial and then change it over to sagittal. And in other cases, we can look at axial angles that are in a sense of low and in a realm of pathological, but you see these excessive curves in the spine, and whether or not this is compensatory to a problem happening at the cervical junction or habitual, which you can see many people who are in computer type jobs, they can hinge at the neck excessively, perhaps even scarring up tissue here, fibrotically causing tissue to scar up in that position, and therefore having an excessive angle in the neck. Another aspect we can look at, and as we mentioned, if there is only a axial view, then you just simply change the multiplanar to sagittal, and you'll get your the view you wish. And you can see sometimes you'll get this. I couldn't find the one scan that actually had some excessive bone growth, probably from injury or from birth. But you can see that the angle slope of the clivus is fine here, but outside of the visibility of the dens. So in cases like this, you'll have to use just kind of following the dural path and the best you can. Usually at the top bump of the clivus here is going to be your angle. So I can put that to the posterior side of C2 and lift a little bit. We're at 130. And cases that are very low, you want to look for the condyle, any kind of platybasia of the skull, and seeing if there's any flattening of condyles and any other aspects. You may, of course, need to look at McGregor's or Chamberlain line to see if there's any basilar invagination, which we can pretty much see on the eyeball. And of course, if I take this and come here, you can see it still follows the same line of the clivus, and so that's why you can hit that superior part of the clivus bone. And that'll close out doing the CXA, the clivo axial angle, and want to just emphasize the fact of doing this. You want to read through the full article because you want to get the scope of who they're assessing in this and ensure that, even though they're looking for brainstem compression, does a low CXA mean brainstem compression? And you'll see that's not exactly the case. As you're looking for example, clinical metrics, who were they looking at? What was the situation with each patient? I have assessed a number of EDS patients, dancers, very flexible, very strong. One of them had a pathological CXA, but they are very healthy. They had a different problem that was causing their symptoms. So don't consider that a low CXA is run and get fusion. You want to assess all the clinical metrics in regards to craniocervical instability or axial instability. Uh, and that is it. So stay tuned for more videos on looking at other metrics for assessing CCI.